I mean, we've been very lucky to have Ibrutinib now for close to a decade since its original approval, and it's clearly a very effective drug for patients and still has an important role in the treatment of the disease. I think particularly as we see some of the early combination data now for Ibrutinib plus venetoclax and seeing how that's maturing into the phase 3 setting, we anticipate that will get an approval at some point and become a nice option as a time-limited treatment. But as we think about continuous therapy with BTK inhibitors, I do think there is definitely an appeal of the second generation like Acalabrutinib and Zanubrutinib, because when you're keeping patients on drug for a long period of time, you really want to minimize the risks and toxicities, particularly in older patients who have cardiovascular comorbidities. So I see a growing role for the next generation of these BTK inhibitors in the clinic. And then we've also seen very exciting early data from Pirtobrutinib, the non-covalent inhibitor. We'll see an update on those data at this meeting. And I think that's also a very exciting molecule, both from an efficacy standpoint, seeing equal response rates in patients post-covalent BTK inhibitor as patients who are BTK naive. And then also in terms of durability, looking very good, as well as tolerability of that agent.